Okay, LLSA 2021 for emergency medicine. This article is intramuscular midazolam, olanzapine, ziprasidone, or haloperidol for treating acute agitation in the emergency department. Salim, take it away.
Yeah, this was an interesting study. So, agitation really commonly seen in the emergency department. I think anybody who works in the ED has dealt with this. The cause is usually undifferentiated. I mean, every once in a while we'll find out that they did a line of meth or coke or something, but it can be from like alcohol, it could be from any type of drugs, psychiatric illness itself, or just an underlying medical condition like hypoglycemia, for example. And the interventions for agitated patients is usually to reduce risk of serious harm to the patients and to the staff. And most of us kind of follow an algorithm. Verbal de-escalation first, followed by a little show of support, trying to kind of get them to calm down just by talking to them. Sometimes in people who are cooperative but a little bit anxious or agitated, they'll tolerate PO medications as a next step. If they're not being so cooperative, some of us have had to move on to IM and IV medications, chemical restraints, which is what this paper is really about. Ultimately, physical restraints and intubation are kind of last resort type options. Now, there's lots of medications out there, and there's no one that's been proven superior. And the purpose of this study was to specifically look at intramuscular injections of olanzapine, haloperidol, ziprasidone, and midazolam for treating acute agitation. Now, these four agents, they've not ever been previously studied head to head, so it's kind of an interesting paper to look at. Unfortunately, many people or some people might have droperidol or ketamine or other benzodiazepines available. That's just not what was studied in this trial.
You know what I like about this study, Salim, is this is something we do very, very often. The IM injection for the agitated patient, because they're not doing PO and they're not doing IV. And all of those medications except one are in my armamentarium in terms of when I treat this. So I like to know what works best. Granted, I use a lot of them in combination, but this is a nice kind of study to give me some insight into, well, what are my options and which one works the best?
And we'll talk about that a little bit when we get into some of the discussion and limitations, but I agree with you. It's usually a combination of medications that we're using and not just one by itself. But this was conducted at a single ED in Hennepin County at their medical center in Minneapolis, Minnesota. And it's interesting when you go through the methods, they initially planned it to be a prospective, double-blinded, randomized clinical trial. They submitted it, and then the FDA said, yeah, we can't approve this because we're not sure whether these participants who are agitated can provide informed consent. So they changed what they did, and they said, we're just going to make this a prospective observational study. So look, it's the best we can get. They tried to get the RCT, but it is what it is. So inclusion were adult patients greater than or equal to the age of 18 who required treatment for acute agitation. Exactly what you and I are looking at. Exclusion if they were under 18, so adolescents and kids, prisoners, and then patients in custody of law enforcement. So if they were brought in by the police, for example, they were all excluded. Now, because they had to change their methodology, it's really interesting. They did these 3-week blocks of each medication up to 15 weeks. So for 3 weeks, we're just going to do haloperidol 5 milligrams. And then for the next 3 weeks, we're going to do the haloperidol 10 milligrams. And then so on and so forth till they got up to the 15 weeks. Now, I think all of us would agree all 4 of these medications would be considered standard care. And the relative risk differences between the agents are pretty minimal. I mean, we could talk about QT prolongation and some of that stuff with haloperidol, but overall, I think they're all pretty equally safe. Now, all treatment choices were basically by provider discretion. So if they were in the 3-week block, they did Haldol. And then if they needed something else, for example, then they would give them, rescue medication, some other thing, which is what you and I were alluding to, that most of us are doing 2 types of medications. We're not just doing one, but that's what the study looked at. Now, the research associates, they were available 24/7, and they screened and enrolled consecutive patients, which is always great. So this wasn't a convenience sample. It's not like they were taking biopsies and doing it from time to time. They took everyone that came in 24/7, 365. They used something called the Altered Mental Status Scale, which is used to determine the severity of patient agitation. And the scale ranges anywhere from -4 to +4, -4 being the most sedated and +4 being the most agitated. And when we get to the primary outcome, you'll see that they're shooting for something less than 1, which is where the patient is basically cooperative, right? Not completely knocked out, but not so ticked off that they're potentially causing harm to themselves or someone else. Now, after the medication was given, research associates measured and recorded this EM-LLSA scale at 15 minutes, 30 minutes, 45 minutes, 60 minutes, 90 minutes, and 120 minutes. So we have a lot of data points to look at here. Now, I already said the primary outcome was their altered mental status scale score at 15 minutes after administration of medication. And again, this is defined as a score less than 1. They had a ton of secondary outcomes. You can see them on the slide here. I'm not going to read through all of them because people can read on their own, but there was lots of little interesting things here, like adverse events. How long did it take for people to get sedated? Did they require rescue medications? So I think these are all good secondary outcomes to look at.
And one of those outcomes, Salim, just to clarify, because I was a little confused initially until you pointed out, was the rescue medication is a second medication to get them more sedated, as opposed to if we're thinking about a rescue medication for over-sedation, like with a benzo.
That's absolutely correct, and that's what was left up to the physician discretion. That the primary medication was chosen, right, based on the block you were in, but then the physician could give whatever else they needed to get the patient to that score of less than 1 to get them to be cooperative. So they included about 127 patients in each of the 5 treatment groups. So this is about a total of 635 patients, if my math is correct. And they were looking to find an 18% difference between each of these medications, which is, I don't know, I guess that's decent. 18% is kind of an interesting number that they picked because these have never been compared. So they just said, this is what's going to be clinically useful. And that's what they were looking for statistical significance. Now, in the final analysis, it ended up being that there were 737 patients that were actually included. And the one thing I want to point out here, Matt, is that agitation was due to alcohol intoxication in 88% of these patients. So this wasn't truly undifferentiated patients, right? These were drunks that were coming in.
Yeah, surprise, surprise. And I think also the male and younger male cohort was strongly represented as well in this group of patients.
100%. And look, this table, it's really dense and complicated, but I'm just going to narrow this down. I'm just going to tell you verbally. But at 15 minutes, midazolam showed the greatest efficacy compared to all other antipsychotic arms by a significant margin, except to, interestingly, olanzapine, which was kind of an unexpected finding for the authors. The midazolam was better than olanzapine by numbers, but it just wasn't statistically significant. It didn't hit that 18% or greater difference.
You know, Salim, that was an interesting outcome for me with the benzo because oftentimes, if we're going back to that alcohol, right, I tend to be a little bit more wary of mixing benzos with alcohol, and I'll usually go for my antipsychotics. So it's kind of a comfort to me to know that, yes, this benzo worked the fastest and is relatively safe in this cohort of patients.
Yeah, absolutely. And that's one of the big pearls from this study is that at least in 88% of the patients who were brought in for agitation due to alcohol, it's no surprise that midazolam, the benzodiazepine of the 4 medications, was the fastest in onset of getting the patients kind of calmed down and cooperative. Now, they get into a lot of this like kind of statistical hocus pocus, and they calculate these hazard ratios, and they used midazolam as the reference value because that was the one that was the fastest. And they compared basically all the other medications to midazolam. And what they found is that it certainly had the best hazard ratio compared to all of them. And then when you look at ziprasidone, the hazard ratio is in the upper limit of the 95% confidence interval for both the ziprasidone and the haloperidol were less than 1. So that means that the midazolam was most effective for adequate sedation compared to those 3 regimens, ziprasidone, haloperidol, 5 milligrams, and 10 milligrams, but that was not the case when it was compared to olanzapine. Now, this is what you were alluding to earlier about I get a little nervous about giving benzodiazepines in these alcoholics because I don't want to sedate them too much. But interestingly, adverse events were really uncommon with no significant differences between treatment groups. So that's also an added piece of information that might, take away some of that reservation for you, Matt. And EKGs weren't required pre and post medication. So there could have been some missed cardiac dysrhythmias, but there really was no untoward like torsades de pointes or cardiac arrest at all anywhere in this study. And so I know a lot of people harp on like, well, if I'm going to give the haloperidol, I need to have a pre-medication EKG to look at that QT prolongation. But they didn't do that in this study, and it didn't seem like it caused any clinically relevant bad outcomes.
And that makes clinical sense, Salim, right? Because when an agitated patient, they're the hardest patients to get EKGs on. And the reality of my practice is I am not getting EKGs in patients that are agitated that I'm giving Haldol to. I'm just giving the Haldol. And if they have an issue, then I'll do the EKG down the road. But oftentimes, I just never get it.
I'm exactly in the same boat as you. I don't even bother because good luck getting them to stay still before you give them the medication. So yeah, I think, this isn't a fault of the authors. I think this is just what clinical practice is. Now, it's important to note that because the adverse events were so uncommon in this trial, that we can't really make hard conclusions about adverse events, right? There was too few. And so you can't say that it was numerically or statistically relevant based on the small numbers. Now, this is where I want to get into some of the limitations of this study because I really applaud the authors. What a tough study to put together, tough patient population, but one that we all deal with. And it ended up being an observational prospective study design, and they had like lack of randomization and blinding, but they tried to mitigate that by enrolling large blocks of consecutive patients 24 hours a day. So they didn't do a convenient sample, they did a consecutive sample, which I kind of alluded to earlier in this talk. And then they minimized exclusions, right? And then the other thing they looked at is, how was our protocol adherence? Did we follow what we said we were going to do? And it looked like they did a pretty good job in this study, and they missed very, very few patients. So I think they try to mitigate a lot of those biases of it being observational by doing that. Now, the other thing I want to say here is that the findings of this study, it may not be generalizable to the ED that some people work in. And that may be because the etiology of the agitation might be different. Also, the medications available might be different. And so that might be a small little limitation, but I think this gives us some useful information on at least 4 medications that are possibly out there. Now, one comment the authors make here is that this is a pitfall, that olanzapine in elderly patients with dementia should be avoided. And it's due to the antimuscarinic side effects. It can actually make their agitation worse. And so this is really important. So if you have a patient, and I have them come in from nursing homes sometimes with dementia and increased agitation, olanzapine is one of the 4 medications listed here that we want to kind of avoid in these patients. So now I'm going to get into some of the discussion of this paper, and I think some of these things are worth mentioning. So first of all, IV droperidol and IV olanzapine, or in combination, have demonstrated sound effect in treatment of agitation in other prior studies. The comparison between midazolam and olanzapine approached significance, but unfortunately the confidence intervals crossed 0. So IM olanzapine performed with greater efficacy than anticipated. Even the authors admitted that. And maybe a future study could compare IM midazolam to IM olanzapine head to head, and maybe reconsideration of their power calculation to see what an actual appropriate difference would be based on this trial. The second thing is midazolam is known to have a really short half-life. It's about 2 to 7 hours, and 44% of the patients in this study required a rescue sedation after initial administration of midazolam to make sure that they maintain their adequate sedation. So one thing that's important, and one of the things that Matt and I were talking about, is that this is why we tend to use things in combination. Midazolam kind of gives you that early effect, and then maybe something like haloperidol will kind of give you that longer effect. And you kind of get this 1-2 punch without having to do a lot of rescue medication. But used by itself, just something to kind of keep in mind. So now olanzapine may be more effective than haloperidol in this population, and it's noted to likely have much lower risk of torsades compared to droperidol. And extrapyramidal side effects are really uncommon with olanzapine compared to other first generation antipsychotics. And so that alone might be a reason to consider this as a first line agent. Now, haloperidol is interesting. If it's used to treat agitation, this study suggests that 10 milligrams is more effective than 5 milligrams, with trends toward a greater efficacy at 30 minutes and need for fewer rescue medications. But I would say that we have to balance that, because we initially want to get control of the agitation of the patient early, but we also don't want to sedate them so much that they're sitting in the emergency department for hours upon hours until the medication wears off. So that's the kind of final thing. And then the last thing I'll say is that we already said this multiple times, but they use monotherapy in this study. And I think most of us in clinical practice, we're using combination therapy. We're using multiple different agents to kind of get that quick sedation, but also not have to use a lot of rescue medications down the line, but also not keep the patient in the emergency department for a long period of time.
The practice changing things for me here, Salim, is because, like you said, I usually use the first generation antipsychotic with a benzo, but I might actually start trying to tailor with some of the newer ones based on the data with olanzapine as another option. Again, still in combination with probably a shorter acting benzodiazepine in my really agitated patients.
Yeah, and that's one of the pearls in this study, is that midazolam IM resulted in a greater proportion of patients adequately sedated at 15 minutes and greater median reduction in the altered mental status scale score at 15 minutes. And so at least at the front end of this patient encounter, it seems that midazolam in these patients, and again, remember 88% with alcohol, worked the fastest. And so this might be a good first line with an antipsychotic to kind of give you that 1-2 punch.
This is Hippo Education.